Hello, everyone. Thank you for the invitation to be part of the 2022 International Health Conference. I'm Jean Tang, Associate Professor at the School of Nursing, University of Washington, Seattle, Washington, United States. I'm a psychiatric and mental health nurse practitioner and a sleep researcher. I'm thrilled to have this opportunity to talk about sleep and its role in health promotion and wellness. Since the theme of this year's conference is health promotion, when it comes to sleep, I thought we could spend some time on the following topics. Here is what I thought that we could spend time on today. One is, in general, sleep and health and its mechanism of sleep-wake cycles, general tips for promoting good sleep, and assessment of sleep. And as healthcare providers and researchers, how to facilitate communication around sleep issues. So first of all, insomnia and its prevalence. Insomnia affect between 10 to 30% of the population worldwide. And some studies show that the prevalence rate can be as high as 50 to 60%. In addition, it is common in older adults and females and people with mental and medical illness to have more sleep issue. Chronic insomnia has been associated with increased medical comorbidity and therefore increased medical cost. It also has a negative impact on a person's quality of life. So how can we make it better? This is a common question that a lot of people ask. How much sleep do I need? And the answer is this can be quite individualized because sleep is subjective, similar to the concept of pain. However, there is a rough range. According to the National Sleep Foundation published this sleep duration recommendation. Sorry, as you can see that during the infancy, it is typical that children sleep more than 10 hours a day. And as we get older, the average number of sleep decreases and started to plateau. And most of the adults requires around 7.5 to 8.5 hours of sleep per night. So for people who are curious about their sleep numbers, I often suggest finding a week when you do not have special events such as appointments or stressors. And during that 1 week, go to sleep and see how long you can sleep in, and then wake up without the alarm clock. If you wake up feeling refreshed and can function well enough without a daytime nap, that is a good indicator of how much sleep your body needs. Sleep is as important to our health as eating, drinking, and breathing. It allows our bodies to repair themselves and our brains to consolidate our memories and process information. Studies have shown that poor sleep is linked to physical problems such as weakened immune system and mental health conditions such as anxiety and depression. So here is a brief summary of some of this chronic sleep issue and common health condition, its association. For example, people have chronic pain like arthritis or cancer pain. Sometimes the pain will interrupt sleep, and people can wake up from the pain in the middle of the night and unable to fall back to sleep. Or people with asthma condition, the difficulty breathing and the side effect of medication for the treatment of asthma. Or people have thyroid dysfunction, whether it's hyper or hypothyroidism, it can impair sleep quality as well. Nocturia is a big thing, and people living with heart failure, prostate issue, diabetes, the nighttime urination, frequent use of bathroom can interrupt sleep. GERD is another condition that's often overlooked by providers and people in terms of its potential of interfering with sleep. A lot of time people has GERD but not aware of the condition, and they come to their provider complaining about sleep, whereas the root of the problem actually is in the GI system. And also people who are going through menopause phase, the vasomotor symptoms like night sweat or hot flashes can cause sleep disturbance as well. Sleep and mental health. Sleep is the vital sign in mental health, and it's often the one of the common chief complaint in psychiatry. So, for example, people who have mood disorders, such as depression or bipolar, the ruminating thoughts, worries, or staying up at night, working on projects in patients with mania or hypomania, this can impair the sleep. And anxiety disorder, people having an anxious thoughts at night, or waking up in the middle of the night with anxious thoughts, it can impair sleep as well. Clients living with schizophrenia, sometimes auditory hallucination or paranoia thoughts, visual hallucination can contribute to sleep issue. People with post-traumatic stress disorder often have nightmare and therefore poor sleep quality. ADHD, sometimes people with ADHD staying up late at night to focus on one project, and also the side effect from medication such as stimulants can interfere with sleep. Neurodegenerative disorders, the sound downing and day-night upside down dysregulation is quite common in people with dementia or neurodegenerative disorders. So that's something to think about when someone has sleep complaint. The number one thing is to think about, okay, so we have someone who is complaining about sleep issue. Is there any underlying medical or mental health condition that contribute to this sleep issue? If yes, the root of the problem needs to be addressed first. And I thought it would be interesting to talk about how does aging affect sleep. As we get older, our sleep composition changes. Research has shown that older adults tend to, one, have less rapid eye movement, REM, which is the dream state sleep. And second, older people tend to spend more time in the lighter sleep stage, which is the N1 and N2 stage. In addition to the age-related physiological changes, there are also sleep architecture change. And then waking up at night due to health conditions or medication that we mentioned in the previous slide. And then also daytime napping because the lack of structured daily routine, or there's a shifting in sleep schedule because sometimes, people who don't have to work or don't have appointments, they get to sleep in and therefore push the sleep-wake phase to a later time and then dysregulated the cycle. And then for older adult, once the sleep-wake cycle is being disturbed, it takes longer for people to recover from the baseline. And so people often ask, okay, in older adults, if there's some sleep issue, should I be worried? Okay. So I would think that, we don't need to be overly concerned if we notice the change that's age-related change. However, we would encourage people to check with their healthcare provider if the changes impact their daily functioning and the quality of life. And I think that's the key words. If their daily functioning and quality of life has been impacted, then that's when we say, yeah, the sleep issue needs to be really addressed and perhaps looking into treatment options. So next, I thought, we can talk about how does sleep work in order to really understand and implement the effective treatment plan or patient education, or think through a research question. It will be helpful to understand how does sleep work. So there are two regulating processes that contribute to sleep. One is sleep pressure. The other is circadian rhythm. So first, the sleep pressure, that's how long the person has been awake. When we wake up in the morning, the sleep pressure is usually at its lowest. Okay? And as the day goes, we slowly build up the pressure for sleepiness. And during this process, any interruption that disrupts this process of the pressure building could impair the sleep. So we want to avoid taking too long of a nap, especially late in the day. And we also want to limit the nap time to less than an hour. We want to avoid sleeping in late or staying in bed longer than needed to preserve this pressure building process. And so when it's 11 p.m. at night, the pressure is at its highest, and so can promote the sleep induction. The second process is circadian rhythm. That's the timing in which your body wants to sleep. The human body likes to sleep when it is dark out and at the same time every day. So synchronization with the sunrise and sundown and regularity is the key. Also, the melatonin secretion is in response to the darkness, and melatonin releases 4 hours before bedtime. So make sure to allow time to unwind and ease into the evening routine is one of the principles that we should consider. So we talk about the regulating processes. How about some of the neural anatomy of sleep? So sleep is controlled by the hypothalamus in the brain. The arousal centers is in the top of the brain stem and is in the hypothalamus. Through the neurotransmitter, when the neuron in the arousal area are active, the cortex remain active, and then the person stay awake. Of this mix, orexin is part of the excitatory signals. And then we also have a suprachiasmatic nucleus. This area receives light signals directly from the eyes through the optic nerve. The light then resets the internal biological clock to correspond to the day-night cycle. The suprachiasmatic nucleus promotes the wakefulness by producing a powerful alerting signal that offsets sleep drive. On the other hand, the suprachiasmatic nucleus promotes sleep by turning off the alerting signal. And in addition, it actively maintains sleep throughout the night, even after sleep drive has dissipated in the second half of the night. So the suprachiasmatic nucleus area is important for sleep onset and then for sleep maintenance. And then we have ventrolateral preoptic nucleus. It is a small cluster of neurons in the anterior part of the hypothalamus. Ventrolateral preoptic nerve cells are responsible for the onset of sleep by blocking histamine and the wake signals. During the non-rapid eye movement sleep, the ventrolateral preoptic neuron is active and it releases inhibitory neurotransmitters, mainly GABA and galanin. And these two inhibit neurons of the reticular activating system. They are involved in wakefulness and arousal. So in summary, the sleep mechanism, it is a flip-flop switch. The sleep circuit is known as the flip-flop switch. We have a circadian waking drive that is primarily histamine and several other neurotransmitter signals. They are responsible for keeping us awake. We also have homeostatic sleep drive. That's the ventrolateral preoptic nucleus that we mentioned in the previous slide. These are responsible for onset of sleep by blocking the histamine and the wake signals. In this homeostatic sleep drive, GABA, which is inhibitory transmitter, and melatonin are one of the key player in this mix. So the balance between sleep and wakefulness is the result of the mutual inhibition between wake-promoting neurons and sleep-promoting neurons. So sleep hygiene. We talked about the two processes of sleep, circadian rhythm and sleep pressure. And so translating that into the patient education, which is the sleep hygiene, is can be summarized in this slide. Me as a psychiatric provider, I find it is very helpful that whenever my patients have a sleep complaint, I would go through the sleep hygiene with them, and that usually clear up a muddy clinical picture before we have to jump into treatment. A lot of time, the triggering factors is one of these elements that's listed on this slide. And the sleep issue could be resolved without medication if we properly identify the cause of the problem. And this slide is quite straightforward and people can read through it. But I want to highlight a couple of things. One is the caffeine intake. People may not know that caffeine half-life in the human body is long. It's 8 hours. And that means if I had a cup of coffee at 3 p.m., by 11 p.m., there is still 50% of the caffeine in my system. So that is really something to watch for, and doing a good assessment, like a daily routine assessment with the clients who have sleep complaint would be really helpful in identifying these potential factors that contribute to poor sleep. The other thing I want to point out is alcohol. A lot of people use alcohol as a sleep inducer because of its central nervous system depressing effect. But people often suffer from midnight awakening and not knowing why. Mainly, the midnight awakening associated with alcohol consumption is because of the beta brainwave, which is the high frequency brainwave, rebounds as alcohol wears out in the system. And so that's another thing to pay attention if someone consumes large quantity of alcohol at night and complaining about midnight awakening. So my understanding is that the audiences of this conference are educators, clinicians, and researchers in healthcare related field. I want to talk about common sleep disorders and related assessment so that we can apply to our work. These three are common sleep disorders. They are insomnia, restless leg syndrome, and sleep apnea. So I want to emphasize again, sleep is subjective. So we have to rely on a good self-report data to be effective when doing our assessment and formulating a treatment plan. First, let's look at the primary insomnia. Basically, it means for someone, it takes more than 30 minutes to fall asleep. That's one of the criteria. And then there are 3 different subtypes. People can have more than one subtype. So one of the subtype is unable to fall asleep. So someone who is having trouble falling asleep. Or someone who, the second subtype is having difficulty to stay asleep. Or waking up too early. Again, a person can have more than one subtype in the insomnia. There's some key terminology or concepts that I want to kind of highlight. One is hour of sleep. That means from the time this person go to bed to the time they're out of the bed. Okay. And then there's another differences is the time, they go to bed, and then the time they actually fall asleep, and then the time they wake up, and the time they actually get out of sleep. And later we will talk about why this is important to know the terminology and then the hours for each. So one of the criteria for someone to be diagnosed as having insomnia is not only, having trouble falling asleep, and then meeting one or more of these subtypes. There's also sleep quality impairment. For example, waking up feeling unrested, not feeling fresh, or the sleep issue has impacted the daytime functioning, whether it's energy or concentration or their daily functioning. And then there is frequency and then the timeline. This issue has to be at least 3 nights out of a week for at least 1 month. For clinical and research, there is a well-validated, well-studied sleep scale that people often use, and it's called Insomnia Severity Index. It's easy to implement. It takes 5 minutes to administer, and this scale is reflecting of these diagnostic criteria described here. So it has this 3 subtypes of the insomnia. It also captures how satisfied this individual is with their sleep pattern, and whether how noticeable to others of their sleep problem, if there's any. And then are they feeling distressed or worried about their sleep problem? And then most importantly, there's the impairment to their daily functioning, and a concentration, memory, and mood and fatigue. And then down here, you can see if someone is scores 15 and above, that meets the criteria for clinical insomnia. So personally, in clinical and research, I find this scale to be very helpful. And then this is available to the public with the permission from Dr. Charles Morin. Okay, so we covered in primary insomnia. The second common sleep disorder is restless leg syndrome. There are 4 quick questions that people can use to screen RLS. So the questions are, do you move your legs because of discomfort or disagreeable sensation in your legs? Do you move or rub your legs to relieve the discomfort? Are these symptoms worse at rest, but relieved at least temporarily by activity? And are these symptoms worse later in the day or at night? If someone answered yes to all 4 of these questions, then restless leg syndrome is highly likely. Again, this is a screening tool, not a diagnostic tool. But if someone, whether it's your patients or your research participants, answered yes on all 4 of these questions, then they probably need to be referred to a sleep medicine specialist for further evaluation. And the third common sleep disorder is sleep apnea. And so there are simple screening questions. Do you snore loudly? Do you often feel tired, fatigued, or sleepy during daytime? Has anyone observed you stop breathing during your sleep? Do you have or are you being treated for high blood pressure? If someone answered yes on 3 or more of the 4 questions, they are at high risk for obstructive sleep apnea. And again, this is a screening tool, and then this tool is called Stop Bang. So the stop part is the 4 question we just talked about, and then bang is the BMI. If they have high BMI, they are 50 years or older, their neck circumference is 40 centimeter and greater, or their male gender, they are high risk. So we just did a quick review of the 3 common sleep disorders. For someone who are interested in knowing more about their sleep-wake pattern, sleep diary is often recommended. This is more for high functioning and motivated patients who would like to gain more insight into their sleep. And the sleep diary captures the time people go to bed and the time they fall asleep, and the time they wake up, the time they finally get out of the bed, and then the numbers of midnight awakening. To do a good sleep diary, a 7-day sleep diary is recommended because then it captures the pattern. I find this exercise extremely helpful from the cognitive behavioral therapy point of view. Through this exercise, people often become more reflective about their bedtime routines and sleep patterns. A lot of time, people were surprised that their sleep hours are not as bad as they thought, or they're more cognizant about how late they have been going to bed, and therefore their sleep cycle is off. And the data collected from the sleep diary can be useful for sleep efficiency calculation. And that's a term that sometimes people use. And here's how sleep efficiency is calculated. It's a percentage of the time spent asleep while in bed. So time in bed is the time when they're out of bed minus when they go to bed. Sleep time is the time when people fall asleep and through the time they wake up. Say this person spent 7 hours sleeping and then 10 hours in bed. Their sleep efficiency is 70%. Whereas a normal sleep efficiency should be 85% or higher. For people who are using some fitness tracker, usually there's this sleep number, and so you will hear people talking about their sleep number, sleep efficiency. And I think, again, you know, by having people doing this 7-day diary, sleep diary, and this calculation of sleep efficiency can be really useful as a feedback tool for any individual to assess their own sleep quality. So now we have talked about the sleep and wake mechanism, its neural anatomy, neurotransmitter, and how it translates to sleep hygiene, patient education. We have also talked about how to assess sleep issues and some of the commonly used clinical and research tools to assess sleep. And now let's talk about treatment. The standard treatment for insomnia is cognitive behavioral therapy for insomnia, in brief, CBTI. And I cannot emphasize enough that CBTI is the first line and should be the first line treatment for insomnia, not medication. A lot of time people with sleep complain, they go to their provider and the quick fix is to get hypnotic medication, which may be useful in the short term, but then there's side effect, and then long-term wise, it may not be a good option. So I think, you know, from the health promotion aspect, I think people need to have this awareness that CBTI is the recommended first-line treatment for insomnia, not medication. So CBTI, the cognitive component. In CBTI, the cognitive approach is to help our client identify negative automatic thoughts about sleep, and then challenge those thoughts by identifying more realistic alternatives to those thoughts. And also to discuss how their negative or worrying thoughts can get in the way of sleep, and how sleep will occur naturally without having to try if obstacles such as these thoughts are removed. Also, it includes, you know, helping our clients to schedule a time during the daytime to anticipate worrisome thoughts that they expect may come that night, so they can attempt to address them in the day by journaling about them and then put it away, for example. The cognitive, so that's the cognitive aspect of CBTI. The behavioral components of the CBTI, there is a stimulus control. That means we ask patients to go to bed only when they feel sleepy, and they use the bed for sleep and sex only. If they cannot sleep after 20 to 30 minutes, get out of the bed if possible, because we don't want this cognitive association of bed equals to tossing and turning and sleepiness, sleepless, not able to sleep. And then the other behavioral component is sleep hygiene. For example, in the previous slide, we talk about the limit use of caffeinated beverage, limit consumption of alcohol, and exercise during the daytime, and get enough sunlight, and keep the bedroom quiet, dark, and cool. And then there's also sleep restriction. That is to really align the time spent in bed with the time spent asleep. And also try to cut down any daytime napping. And then so the one thing about this sleep restriction is while we try to promote this sleep pressure buildup during the daytime, and then with all the restriction, the sleep should not drop below 5 hours per night. Otherwise, there's concern about fall risk and other kind of impairment for safety issue. For people who are interested in CBTI training, there are a lot of resources. There are online courses. There are books that I included some resources at the end of this lecture, the slides, so people can tap into it. Basically, CBTI is a course of treatment people can enroll themselves in. A typical course of CBTI is 8 weeks, and people will be working with certified therapists to work on the cognitive and behavioral aspect of sleep. So if CBTI failed or is effective but not enough, we need some safety blanket to help this person functioning, then medication may be considered. I want to spend some time talking about medication. So sleep medication, if you look at the history of sleep medication, it's pretty much, it's from the poppy seed to orexin. It's the journey. So in early 1900, the hypnotics is primarily barbiturate. And then in 1960, there came along Valium. Okay, it's basically benzodiazepine, and it binds to alpha-1 for sleep promoting effect, and then alpha-2 for anxiety reduction. 30 years later, in 1990s, there came along the Z drugs, and these are non-benzo. These medication, they bind to GABA alpha receptors, and then these three, Ambien, Lunesta, and Sonata, are some of the common Z drugs that came out in 1990s. And then in 2010, there is doxepin that's FDA approved, It's an old classic tricyclic medication, but then it got FDA approved as a sleep agent. And because it's a tricyclic, it's heavy on histamine receptor, and so the sedation effect. In 2014, there's orexin antagonist agent. One of the example is suvorexin. So these are the kind of the history, the revolution of hypnotics. And here's the list of the Z drugs here, and then tricyclic, and then orexin agent. And I want to talk about this Rameltium. It is the first non-scheduled FDA-approved hypnotic. It binds to melatonin 1 and 2 receptors in the suprachiasmatic nucleus. And because it binds to melatonin, so mainly it is helpful for sleep initiation. And the reason I want to talk about this is, when you think about the sleep subtype, there's sleep initiation difficulty, maintenance, and there's early awakening. So a mindful clinician would really listen to patients' sleep issue first to rule out any medical or mental health condition that contributes to the sleep issue. That will be the root of the issue. Those need to be addressed. If after the potential medical condition has been addressed, the sleep continues to be a concern, then really looking at what kind of subtype of insomnia this person has, and then from there choose the proper medication. For example, if it's a sleep onset, maybe Rameltium that targets the melatonin will be the option. Or if this person is already on tricyclic medication for whose other condition, whether it's medical or mental health condition, then maybe a higher dose can help sleep. And then we also have some off-label medication that's being commonly used as a sleep agent. There's trazodone and Remeron and hydroxyzine. And over-the-counter sleep aids like Benadryl, melatonin, valerian. And I won't go into detail about this because this is not a pharm class, but I want to list all the common medication for you so you have it. These are some of the resources on CBTI. There's some digital apps people can use for CBTI, and then books for general public, books for clinicians, websites for people who are interested in getting more training or education on CBTI therapy. Websites on sleep and aging. There's National Sleep Foundation. I highly recommend this website. And then National Institute of Health in the US, and Cleveland Clinic website. So thank you all for attending to this lecture. I appreciate your interest in sleep promotion, and hopefully collectively we can work together to help everyone have a better sleep. If there's any question, feel free to contact me. Here is my contact information at School of Nursing, University of Washington. Thank you.